Okay, thanks. So I will share my PowerPoint with you so you can follow me when I'm talking about groin pain tonight. And first of all, good evening, everyone. So my bad for yesterday. I got some trouble with trains, so I could not give you guys the lecture of today, but fortunately we can do it today. So thanks for all the participants for being there. So let's start. So my name is Ayrton Sahraoui. I'm a sport physiotherapist in France, and I also work as a sports scientist. Today, I'm honored to speak with you about groin pain. In sports physiotherapy, a condition that is both common and challenging to manage in athletes, we will explore its assessment and management using an evidence-based approach. Over the next 45 minutes, I will guide you through the critical aspects of groin pain, from understanding the underlying anatomy and biomechanics to explore common injury classifications, detailed assessment technique, and phase treatment protocols. We'll also, guys, if you can stop your microphone. So thanks. So we will also review a case study that will illustrate this concept in practice. And finally, I will share key takeaways along with recommendations for multidisciplinary collaboration. So before we begin, I'd like to provide a brief overview of our session. We'll define groin pain and discuss its significance in sports, including prevalence and recurrence. Next, we'll delve into the relevant anatomical structures and biomechanical principles that are essential for understanding this condition. We'll then move on to discuss the classification of groin pain as established by the Doha Agreement in 2015, along with red flags that require urgent referral. After that, we will explore the various assessment strategies and special tests that will help pinpoint the source of pain. The discussion will continue with an in-depth look at the treatment process, which is divided into early, mid, and late phases of rehabilitation. We'll also incorporate insights from current research and evidence-based guidelines through our discussion. Finally, we'll review a case study to consolidate our learning and open the floor for questions and discussion. Feel free to ask me questions during the lecture if you want, or at the end as you want. So, by the end of this session, you will be able to understand the anatomy and the biomechanics, recognize the key muscle, joints, and nerves involved in groin function, and appreciate how their interplay contributes to both normal and movement and injury. You'll be able to identify causes and classification, differentiate between various types of groin pain, including adductor-related, iliopsoas-related, inguinal-related, and pubic-related pain, and understand the implications of acute versus chronic conditions. Apply evidence-based assessment strategies. Utilize a combination of subjective history, objective examination, and special tests to accurately diagnose groin pain. and you will be able to implement effective treatment protocols, understand the phases of rehabilitation, ranging from pain management to advanced sport-specific training, and the role of manual therapy, strengthening flexibility, and neuromuscular control exercises. You'll also be able to advocate for a multidisciplinary approach, appreciate the importance of collaboration among physiotherapists, physicians, coaches, and athletes to optimize outcomes and reduce recurrence. These objectives will serve as the roadmap for our discussion today. So, groin pain is a multifactorial condition that commonly affects athletes engaged in high-intensity and multi-directional sports. It is defined as pain located in the hip and inner thigh region, which can stem from a variety of causes, including muscle strains, overuse injuries, and even referred pain from other structures. Research indicates that approximately 10 to 20% of elite athletes experience groin pain at some point in their career, with sports such as soccer, hockey, and rugby being particularly affected due to the dynamic and demanding nature of these activities. One of the most challenging aspects of groin pain is its high recurrence rate, okay, 10 to 20%. It Many athletes initially dismiss mild discomfort as a temporary setback, only to return to training and competition too early. This premature return can exacerbate underlying issues, leading to chronic pain and long-term performance limitations. It is therefore imperative that we take a proactive, evidence-based approach in both the assessment and management of this condition, ensuring that we address not only the symptom but also the underlying biomechanical and functional deficits. So understanding the anatomical structures involved in the groin pain, it is essential for both the diagnosis and the treatment. So the muscles, the adductor group is central to groin function. This group comprises several muscles, including the adductor longus, the adductor brevis, and the adductor magnus, as well as the gracilis and the pectineus. In addition of these muscles, the iliopsoas and the rectus abdominis are essential for the hip stability and movement. Each of these muscles has specific roles. For instance, the adductor are responsible for bringing the leg toward the midline, while the iliopsoas plays a vital role in the hip flexion. Understanding the distinct function of this muscle allows us to target them appropriately during the rehab. So there's two major joints that are involved, the pubic symphysis and the hip joint. The pubic symphysis is a cartilaginous joint located at the front of the pelvis. It provides stability and facilitates force transmission between the lower limbs. The hip joint, being a ball of socket joint, allows a wide range of motion necessary for athletics activities. Any dysfunction in these joints can contribute to altered biomechanics and increased stress on the surrounding muscle. For the nerves, the abductor and femoral nerve are the primary nerve supplies for the groin area. These nerves not only facilitate motor control but also transmit sensory information. When these nerves are compromised, either through compression or inflammation, the result can be pain that mimics musculoskeletal injuries. What about the functional rules okay, of the groin area. In daily and athletic activities, these anatomical structures work together to maintain balance, stability, and effective movements. When one element is compromised, whether by muscle weakness, imbalance, or joint instability, the entire kinetic chain can be affected. This can lead to abnormal load distribution and increased risk of injury. By understanding these detailed anatomical and functional relationships, we can better appreciate how injuries occur and how they should be managed. Let's now consider the biomechanical aspect and risk factor that predispose athletes to groin injuries. The groin functions as a critical joint force transmission during dynamic movements, and any imbalance or weakness can lead to injury. Muscle weakness or imbalance, a common issue in the imbalance between the adductor and the abductors of the hip. When the adductors are significantly weaker, the altered force dynamics can lead to undue stress on the groin region, making it more susceptible to injury. Also, a poor core and hip stability provide can be one of the elements that make the groin area at risk. Okay, the core muscles provide essential support to the trunk and the pelvis. If the core is weak or unstable, the compensatory mechanism may overload the groin muscles. This lack of stability is often seen in athletes who have not engaged in targeted core training stability. Also, sports that require frequent change in direction, lateral movement, or kicking place repetitive strain on the groin. Over time, this repetitive loading without adequate recovery leads to microtrauma, which can accumulate and eventually result in overuse injuries. Training errors, such as sudden increase in intensity or volumes, inadequate rest period, or poor technique, can contribute significantly to development of groin pain. Athletes who push through pain or fail to modify their training based on early symptoms are at a higher risk of chronic issues. These biomechanical factors not only help us understand why groin pain occurs, but also highlight the areas that need attention during both preventing treatment, training, and during the rehab. So let's talk about the DOA agreement. The DOA agreement has provided a standardized framework for classifying groin pain, which aids in both diagnosis and treatment planning. First of all, there's the adductor-related pain. It is characterized by localized pain in the adductor muscles, particularly during activities that involve resisted adduction. But you should be aware that that's not in the course of the muscle. If it's a tear of the adductor, it's not groin pain, okay? It's just a muscle injury. It has to be at the insertion of the adductor on the pelvis. The pain must be located around the pubic area, not in any other part of the adductor. This category is the most common in sports involving rapid lateral movement, such as hockey or rugby, football. Then there's the iliopsoas-related pain. The pain is typically found in the interior hip region. It is often aggravated by resisted hip flexion, of course. Patients might also experience a sensation of tightness in the front of the hip, which can limit their performance during running and kicking, and of course during a hip extension. There's the inguinal related pain, that this is located in the inguinal canal, okay, and may be accompanied by symptoms that mimic an inguinal hernia. Okay, that's another pathology, but the symptoms are essentially the same. You should be aware of that. Activities that increase intra-abdominal pressure, such as cutting or performing a Valsalva maneuver, often exacerbate the pain. And in the last, there's the pubic-related pain. This type is associated with dysfunction of the pubic symphysis and is often seen in athletes with a history of chronic overuse. The pain tends to be more diffuse, presenting as an ache across the lower abdomen and groin. Furthermore, groin pain is classified by its duration, acute or chronic, of course. Acute is usually result from a specific incident, such as a muscle strain or tear, and is often accompanied by a sudden onset of the pain. With appropriate rest and treatment, acute pain can typically be resolved in a matter of some weeks. But for the groin pain, the chronic groin pain, it develops over time due to repetitive micro trauma and inadequate healing. Okay, so we must be aware of the first symptoms of groin pain and not let the athletes keep the pain for weeks and months, because then it becomes a chronic pain. It is more complex to manage because it involves persistent biomechanical imbalance and may require long-term intervention. So by understanding this classification, it is the key to developing an individualized treatment strategy, ensuring that intervention target the specific underlying pathology. But before we talked about assessment strategy, we need to talk about red flags, okay? The most common groin pain is musculoskeletal in origin, but there's also red flags that require immediate attention. Hip fractures, for example, rare in younger athletes, that can be one of the symptoms that young athletes got, okay? The inability to bear weight, the history of a trauma. This is particularly relevant in older athletes, okay? Or those who have underlying condition like osteoporosis. There's the avascular necrosis. There's a serious condition where the blood supply to the bone is compromised. Okay, so that's severe pain, limited range of motion, and you need to refer to a specialist as quick as possible. There's also systemic condition, okay, of systemic illness such as infections, inflammatory disease, or even referred pain from the abdominal or the pelvic organs. Okay, the presence of systemic symptoms such as fever, weight loss, or fatigue should prompt further investigations. It is essential to identify these red flags during the initial assessment to ensure that serious underlying conditions are not overlooked. So let's talk about what we want to talk about, the assessment strategy, of course. So first of all, we need to have a subjective history. Okay, detailed inquiry, beginning by asking the patient to describe the onset, the duration, and the character of the pain. Then the context and the mechanism. Ask about any specific incident or change in training routine that preceded the pain. The aggravating and the relieving factors. Okay, what activities worsen the pain and which measures seems to elevate it. Previous treatment, okay, past intervention or treatment that were attempted and their outcomes, lifestyle, of course, and sport participation. You need to ask that because you'll not treat a professional football player with the same energy and the same mentality. I will say that someone that does one one training per week, okay, that I'm not saying that we should not giving the best to each other, but when someone is when that's someone that lives with sports, a professional, okay, you can't take it like an amateur player. You need to be more specific to each sports, more specific to the demands of the sports, okay, specific to the training schedule also, and be aware of any increase in intensity or volume during the training during the season. Okay, in the early of the season, in the preseason, like right now in France, clubs begins to train for next season, and that's where we need to be focused on, because that's right now that the pains are going to increase because they're increasing the intensity, they're increasing the volume, and 2 weeks before they were in holidays, partying. So you need to know when the pain occur and when do I see the athletes during his season. Then we have objective examination, of course. Observation, the gait, the posture of the patient, asymmetries or abnormal movement patterns, palpation. I will say palpation comes after all the tests that we are going to discuss, because if you palpate the groin area and it give the patient some pain, then you will have pain in everything that you will test. So keep the palpation, okay, but for after all the tests. You have to test the range of motion, of course, active and passive range of motion of the hip, and the functional assessments. Evaluate how the pain manifests during sport-specific tasks or during squats, during split squats, during glute bridge, during any exercises that where you can assess the athletes in front of you. Documenting these findings create a baseline for monitoring progress through the rehabilitation process and helps in tailoring intervention specifically to the patient needs. Okay, you'll also could use imaging, okay, like ultrasound or MRI or X-rays, okay, using these imaging tools in conjunction, always in conjunction with clinical findings, okay? Don't talk to me about a picture, okay? If someone is doing an MRI and is not having any pain, maybe we'll find something. You have to be, of course, good in the clinical findings. And then if the patient has some imaging, then we can correlate those two, but not one, not the other, both together. You'll use to confirm the diagnosis and guide the treatment plan. Special test. Okay, so the squeeze test, first of all, for the patient that may have some pain in the adductor area. Okay, if with the history of what my patient is telling me, I think that's adductor related, like we talked about from the Doha Agreement of 2015, then I will do the squeeze test. Okay, is it positive? Yes or no? Yes, by pain, or noticeable weakness in the adductors? No, no pain, no weakness. If it's more like something that you'll look as the iliopsoas related pain, groin pain, you'll do the Thomas test. Okay, is it positive? Yes, if there's tightness or uh, there's pain. Okay, compared to the control lateral side, of course, always, always in all the testing, you need to compare with the good leg. Then the Vasalva maneuver. Okay, if it increased the pain, you must think inguinal related pain. And of course, like I said before, palpation and strength testing. Always use dynamometer. Okay, I don't know if you guys use it in your clinical activities, but it's now you can buy it with not much. Okay, that's the price are low for the first price are really low. And if you wanted to work with athletes, you need to have anything that can test the strength. Okay, you can't push it with your hand and say, that's great, that's bad. No, you can't say it. You need to be specific. You need to be reproductive. Okay, if I test this day, today, tomorrow, if I'm doing the same test, I will have to keep my framework. Okay, I tested like this yesterday. I tested the same way today. If not, the testing doesn't mean anything. So, for treatment, the management of groin pain follows phased rehabilitation approach, with each phase targeting specific aspects of recovery, of course. Each phase is designed to build up the previous one and ensuring a gradual and sustainable recovery. The early phase rehabilitation, okay, the goal is to focus on the pain management and reducing the inflammation. You, you need to utilize the RISE protocol, for example. Okay, rest, ice, compression, elevation, of course, always the same during the inflammation part. Okay, you can use isometric exercises, and you could use modalities such as electrical stimulation. Okay, that's good for starting the rehab. the stress, the importance of not aggravating the injury, okay, and adhering strictly to prescribed activity modification. Then we're going in the mid phase rehabilitation. Now that's where we want and what we all like. Okay, we need to be clear. The first phase, as physios, as clinical physio, that's always a little boring. Okay, I know. But the mid phase, you can restore strength, flexibility, and stability. Okay, that's where you build up your rehab. You need to introduce resistance exercises, okay, to the adductors, the cord, hip muscles, okay. You need to put weight on the people. Don't be afraid. You need to be careful, okay. Add weight progressively, but the the stress mechanism during change of direction or during sports specific training needs high demands. And to be good in the sport specifics, in the late phases, you need to be good in strength. Okay, I will always be someone that supports people that put weights on their patients. Okay, you need to be okay with, okay, today I'm going to put much weight on my patient, on my athlete. You can't do it with zero resistance. That's not possible. Okay, during a game, in a football game, for example, there will be change of direction at something like 30 kilometers. Okay, the stress on the adductors muscles are way much bigger than what you can do it in your rehabilitation. So for him to be able to change of direction and be the player that he needed to be, you have guys the role of putting weight and preparing the patient for that. In this phase, you can also return to running movements. To begin, ladder drills and slowly introduce running. Okay. Then there's the late phase rehabilitation. Okay. Now you need to be on the field with your patient. I always say that with my colleagues. I'll do it. I'm doing it every Saturday morning. And all my patients that are able to go on the field, I go with them for 2, 3 hours. Okay. I'm taking everyone and let's go. We're going on the field because strengthening is good, but being specific to the sports and return to the higher level function, you need to go on the field or work with guys that are experts on the on-field rehab. Strength coaches can do it. In some clubs, there's people that work specific on the field. But if you're alone and you have athletes, you can't tell your athletes that he can go training if you don't have if you don't do it with him in the first few days. Okay, you can't be here doing squats and the next day doing some change of direction at the higher speed. That's not possible. So you need to take your athletes with you on the field. Okay, you need to do work on plyometric drills. You need to on dynamic strength strengthening, on agility training, okay, you need to ensure the athletes regain full strength and symmetry. You need to go to the return to play. Criteria for return to sports are not today, there's no real valid in the literature return to sports criteria. But from my expertise or from my point, not expertise but for me, that those are the criteria that I use for return to sports. Maybe you guys use other criteria and we can discuss it. I'm not here to tell you that you need to do this and only this. No, we can discuss. But for me, criteria for return to sports are pain-free, of course. Pain must be ended in the early phase of the rehab. You need to have full function and strength symmetry. That's what we are working on the mid phase. Okay. And then if everything of these are good, we can return to play. Okay. Return to participation, return to play, return to run, return to everything that we can put in the return to sport term. That's during this phase. So this phase is maybe the longer phase because that's where the patients go off the gym and until he can be as performant as before his injury. Okay? So, oh, I was quick today. The key takeaways. We need to summarize the most critical points, okay? First, early diagnosis. By recognizing and classifying groin pain early is vital to prevent chronicity and recurrence. That's a major point. Next, a comprehensive assessment, okay? You need a systematic approach combining subjective history, objective examination, and specialized test is the foundation of effective management. So you need to know the phase rehabilitation, a structured progressive rehabilitation protocol from early pain management to sport-specific training is necessary for a successful return to activity, return to sport. Of course, prevention and education. You need to educate your athletes. Emphasizing load management, proper technique, and a balanced training program can reduce the incidence of groin pain and the recurrence of groin pain. If you're working with kids, please, even if you have never experienced any groin pain in the younger athletes, please educate them by using a proper technique during sprints, during running, during change of direction. Today there's multiple of tests that you could use to be like, okay, this athlete, we need to work on his sprint biomechanic or change of direction biomechanic. And if you guys work with kids, do it the early as possible because the time you will work with them right now is time you'll save them from injuries, from many things. And to be performant, okay, you need to be on the field, first of all. You can't be good in a sport if you're not playing. So if you need to play, you need to be in a good health. You don't need to have, you, you do not have injuries. If you have injuries, you're not playing. If you're not playing, we can't tell that you're good. Okay? So educate child with proper technique and load management. And of course, multidisciplinary collaboration, okay, working closely with other health providers, coaches, and the athletes themselves, enhance treatment outcomes and long-term recovery. And I will invite you to share your questions, experience, or challenges related to the management of groin pain. This is an opportunity for us to learn from each other, and I will also ending by thanking the PTE camp for allowing me for the second time to speak with you for groin pain. We'll see you tomorrow for ACL injury framework, but that's another topic. Today we'll have discussed on groin pain. So feel free to give some experience questions, and if I can help you with you guys, I'll be glad to help you, and maybe you can teach me things. I don't know anything. I'm not Enda King. So you always have to learn from each other. So feel free. And of course, you'll find the studies that I use to build up the course. So I encourage you to go and read these studies. Okay. Those are the principal studies that you need to know if you're treating groin pain. So feel free to ask questions if you have. And of course, there's always the contact information if you want to contact me. I will be glad to answer you the quickest way I can. So I'm waiting here. I have like 10 to 15 minutes for questions. So if people want to ask, open your micro and ask me question.
السلام عليكم يا دكاترة، لو حد عنده أي سؤال اتفضل على طول والدكتور هيسمعكم دلوقتي. Hello, how are you?
pelvic floor affect can the pelvic floor affect in the pelvic affect the groin pain?
I didn't hear the first part of the question. Sorry.
Can the pelvic floor affect in the groin pain?
Yeah, if the pelvic part can have an impact on groin pain, that's what you're asking.
Yeah.
Yeah, of course. The pelvic is one of the sources of the pain, and so I will where is it? Is it here? So here we're talking about the pubic related pain, but when I'm talking about pubic related pain, that's all. It's of course also with the pelvic. The way the anatomical and the biomechanics of your athletes can have an impact on the on groin pain, of course. So if his pelvis is in interior position, that's where you could have some tensions, maybe on all the inguinal related pain, or if it's in retroversion, okay, maybe there's more tension in the iliopsoas. So the position of the pelvis have a big impact on groin pain, but also on many, many injuries, like hamstrings injuries. I work with a number of athletes that have some hamstring strains for the past 2 years, and nobody was able to see what's the big deal. But that's just because there's a rotation and it put more tension in the muscle. So just by teaching them how to control the pelvis, okay, for groin pain, but also for other injuries, you need to work on specific drills to learn to your patients or your athletes to control how the pubis, the pelvic, needs to be. Did I answer your question?
Yeah. Thank you.
You're welcome. Any other questions?
دكتور مارك حضرتك رافع ايديك فهتسأل سؤال ولا ايه؟
How how can I prevent recurrency?
The recurrency?
Yes.
Oh, what about the recurrency? I didn't hear the
Recurrence
first part.
of groin pain after the end of treatment. How can recurrence of groin pain
How can we
prevent
prevent
it?
recurrent groin pain? So, first of all, by doing a good job in the first place. Okay, if you guys do a good job in the first groin pain or any injuries, and here it's for the groin pain, but for any injuries, if the first rehab is good, if you focus on the good things,
Okay.
you always have better chance for your patients to not have any injuries after that. But sometimes that's not enough. You can do a great work and boom, 2 years after he comes and tell you, I got pain in the same thing that 2 years before, blah, 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 blah. Okay. So you need to, that's why I'm talking about at the end, of course, the education. You need to educate your patients, tell him that maybe if he had an injury, there's no any other how I can tell you that. So the number one risk of factor of injury is a previous injury. So if someone comes to me with a groin pain, the risk factor number one is that he already had a groin pain before. So you need to teach them what to do, what was wrong, and to teach them, okay, now you're okay, we treat the problem, you can go back to your activities, but be careful, okay? You had an injury, you need to be focusing.
More careful.
Okay. I always give the example of Cristiano Ronaldo. Why he is one of the best players to ever live. on the planet, because he always work on his body. And then, that's 20 years without any major injuries. That's because he was educated to take care of himself.
Okay, thanks.
Doctor.
Please, how can I differentiate between the groin pain and other pelvic pain?
Can you differentiate the groin pain from what? I didn't hear. There's another microphone.
From other pelvic pain.
Pelvic pain?
Yeah.
Yeah, that's a good question. That's a really good question. Because at the beginning, I talked about the groin pain classification of DOA. And in here, they're not, if you look at it, they're not talking about hip pain as well. Okay? They're not talking about any pelvis pain. That's really the groin area that we are talking about. If the first thing that you will ask to your patient, is where is the pain? Sometimes there's pain that can be in the groin area, but comes from another region, maybe. But for the most of it, if the patients tell you the pain is right here on the adductor, on the iliopsoas, on the inguinal canal, on the pubic, that's with the special test that we talked after, you can discriminate if it's really a pain from the adductor. Okay, the pain is located on the adductor. I'm doing the squeeze test. It's positive. Okay, now I think it's an adductor related pain. The pain is located on the adductor, but the squeeze test is negative. What do you do? Like every region, okay, from the hip, from the ankle to the shoulder, you'll see and you'll test other things. Earlier, I was talking about range of motion of the hip. Okay, there was pain in the adductor area, but I also checked and there's some rotation, internal rotation deficit, or there's an hip extension deficit. Okay, here it was a lecture about groin pain, so I'll focus on groin pain. But of course, the pain can be from the hip, and you need to know if it's a hip pain or a groin pain, but it can also be from the pelvic. And for that, you need to follow an assessment strategy, like I talked, like subjective history. Most of it, when you talk with your patient, if you take the time to talk with your patient, they will tell you what they have clearly. If you let them talk, and they will tell you, I was pain when I'm doing that, and then I was doing that, and the pain comes, and blah blah blah, and blah blah blah, and okay. So the pain is when you're change of direction, when the adduction, when you're doing adduction movements, when you're doing co-contraction of the adductor muscles and the iliopsoas muscles. Okay. I see. I understand. I'm listening to my patient. Then I'm like, okay, I will do this special test. If they're okay, that's where I need to go. If they're negative, okay, I will retry again. Maybe I missed something. It happened to everyone, including me. Sometimes I think it's something. The tests show me that's okay, that's it. I'm doing rehab. 1 month later, no benefits. Okay, so what do I need? Should I need to follow this again and again? Or maybe, okay, maybe I was wrong. Let's check up again. And sometimes the first time you didn't see something, and that's not bad, okay? But you need to follow always an assessment strategy to help you in the in the in choosing what strategy of treatment you should go after that. I hope I answered your question. I didn't talk too much for nothing.
Oh, no. Thank you.
Doctor, rehabilitation of chronic cases is different from acute cases?
Yeah, for me, acute and chronic cases are not the same. First of all, because an acute, you can be like, okay, before that, he was okay. Okay, and there's something that make him having pain, but you know what's the big deal. Chronic is more difficult because there's also all the cerebral approach of the pain install in the supraspinal and the cortical supraspinal nerves, and that's really is the hardest part. Okay, that's not really a structural pain in the groin area, but more like there's some adaptations that was that occur, and that the adaptations that you need to change, and that's really difficult if it has been here for months or years.
What's the cornerstone of rehabilitation of chronic cases?
For chronic cases, you will follow the same framework as we talked before. Okay, the framework is the same for acute or chronic groin pain, but you will focus more on compensatory strategies that the patient kept. Maybe the first time you or the person that treat him before missed something, and this thing stay and stay and stay, and then you will need to work harder on the drills, for example. Okay, the patient isn't good in controlling his pelvis, okay, but it's there for years. Now you need to begin another lesson to him. Okay, take more time, be more careful, because you know that the pain is here for months, but the treatment overview is the same at the end. Just it takes more time, and you need to be more patient and more focus on any compensatory strategies.
So at early phases I deal with pain, just pain, or we start eccentric exercises.
Yeah, in the changes from acute and chronic is that in the acute there is some inflammation okay, that you will have to work on. In the chronic phases, there's no more inflammation. So you can work on isometric or eccentric before acute groin pain.
Yeah. Okay. Thank you.
Doctor, I will need to tell you a question. I know that there are symptoms and the location of the pain is not real, and the real location is somewhere else. How do I know where is the real pain? I mean,
So if you need to know by comparing, of course, is the patient have any imaging also? If he tell me there's pain in the adductor and you have some ultrasound that confirm that the adductor is in pain, then you'll be okay. The clinical and the imaging correlate. If you don't have any imaging, you need to do the test that we talked earlier. Okay, maybe the location isn't where the problem is. That can happen. But if the location and the test are positive, there's like more than 99% of chance that you're assessing the good way. But if the location isn't correlated with special tests, then that's where you can work on the biomechanical. Okay, there's he experienced pain here, but when I'm testing here, that's not painful. Okay, what can cause pain? For example, in the adductor, the patient feel tense in the adductor. You do the squeeze test, not negative. Okay, that's not an adductor related pain, but something make him have pain in the adductor. Okay, take a step back, look at him. What can put pressure? What can overuse his adductors? You can go low, look at his knee, even lower, look how he's standing. Maybe his foot isn't going well, so it put more pressure on the internal group muscles, or maybe it's from upper, maybe he have a shift from the core stability. Okay, he shift his body and that puts more tension in the adductor. The pain and everything I talked before, you need to look and listen to your patient. If there's one takeaway message is, okay, listen to your patient, what is he telling me, and look at him. Okay, maybe by looking at him, you will see compensatory patterns and you'll be like, okay, I think you have pain here because you are like that, and that puts more pressure here. And test, retest, always. Change the rehab if there's no improvement. Okay, retest, do something else. Don't do the same thing for 4 months and 4 months later say, oh, I don't know, go see another practitioner. No, if there's no improvement in the first 2 weeks, there's not going to have any improvements in the next 2 weeks. Okay, the improvements are really rapid. Okay, So test, retest, look at your patient, ask him how he feels. Okay, maybe send him doing ultrasound, MRI, if you have any suspicious, and then you correlate those imaging with your clinical expertise.
Thank you, Doctor.
Doctor, can I use EMG for diagnosing overactive muscles or pain, or should I depend only on subjective tests like Thomas and other tests?
You also can use your EMG, of course. I will always be glad if you use as many tools that we have. Okay, that's a great thing if you can have EMG in your clinical practice. Test, and maybe you will see overstimulated or understimulated muscles, but don't focus only on the EMG. That's all. If you correlate EMG with your testings and with everything that your patient's telling you, your athlete is telling you, that's another thing that you can add and gives you more credit and help you to be more specific, of course, but don't use it just for using it.
Yeah, thank you, Doctor.
So I will take one more question and then I will have to let you guys go. So if anyone has one more question, and if not, you can also join me by all the information here. If maybe you have question and you don't want to ask it today, feel free to contact me. Okay, so I'll take this for a no. So thank you guys for tonight. Great talk at the end. The first part was boring, only